Let's see now indication according to the PVR stage. First, we have RD without any signs of PVR that I have named stage 0. It concerns retinogenous detachments, meaning without vitreous traction, for the vitreous is not detached. From a less dense part of the vitreous, a small quantity of liquid passes through the tear and is partially pumped by the pigmented epithelium. This explains these detachments' characteristics. Transparent retina with pseudo-schizic aspects, ischemic new vessels, intraretinal cysts, and demarcation lines left behind as the detachment slowly progressed. Here we encounter RDs with atrophic holes and equatorial lattice degeneration. Here 3 holes with 2 cysts, 1 hole at 6 o'clock with a cyst in back, and 2 holes at 8 o'clock with another cyst, and RDs with dialysis. Traumatic, most of the time nasal superior, or idiopathic. In these cases, the vitreous is healthy. There is no traction or retraction. A simple buckling and/or gas injection will allow the problem to be resolved. There is no indication that a vitrectomy is necessary, except for indications independent of the PVR stage, operating complications, and when pathologies are connected to the posterior hyaloid, as the next 3 examples point out. First, we have the case for RD with idiopathic macular hole in high myopia. The hole is created by a more or less evident macular retraction syndrome. Here it is evident. We can see an epiretinal membrane that we will dissect and remove without too much difficulty. Before noticing that subretinal fluid removal allows for the perfect retinal reapplication. Often, however, the membrane is not very visible, and one must search for it as one does for an idiopathic macular hole. This can be difficult and take a very long time. But it will only be after this long and tedious procedure that a simple gas injection can be considered as a sufficient treatment. If the posterior hyaloid removal is correctly done, there is no reason to perform a silicone oil injection when the retina is soft, without traction nor retraction. Second, we have RD with idiopathic posterior hyaloid fibrosis. This concerns detachments without tears, either posterior, here in nasal. There is no intravitreal pigment and no PVR. The posterior hyaloid is always thick and adherent. Its dissection and removal allows spontaneous retinal reapplication. It can also be peripheral, like a ring, due to anterior vitreous contraction. Posterior hyaloid is thick and adherent here as well. Peripheral vitreous removal also allows spontaneous retinal reapplication. Thirdly, we have RD with optical pits, treated by some surgeons by a primary procedure, vitrectomy. For these young patients, considering the cataract risk, I always prefer, in the hours before the operation, to perform 2 krypton photocoagulation rows on the temporal edge of the pit where the retina is detached. A 0.4 cc injection of pure C3F8 and a positioning for 8 days are usually sufficient. I reserve vitrectomy for when the above procedure fails. In between stage 0 and stage A, there is an intermediate stage where the vitreous is detached, but without great risk of PVR. The detachment of the vitreous can take place on an RD by an equatorial hole, giving the image of a 2-step detachment. On an RD with idiopathic macular hole and high myopia, or on dialysis. In each case, the intravitreal pigment epithelium is the consequence of PVD. It may also be an RD with a microtear in a large pair of buttocks, which signals the entire character of the PVD, and thus indicates that the potential of retraction is minimal. In all of these cases, as with retinogenous detachments, the indication for a vitrectomy is quite rare indeed.